Hello, pharmacology friends. Another chat with Dr. Bracht. And today we're going to focus on respiratory system drugs and drugs to treat urinary antispasmodics. So let's meet your first client. Your client is Mr. Reinhardt. He's 75 years old. He's a retired naval officer. He's been a long-term smoker. He has some urinary incontinence. He has also COPD related to his long history of smoking, and he is on continuous oxygen. So let's take a look at the drugs that he's going to be on. So here's his list of medications. He's on Oxybutynin, which you know is an anticholinergic, and that is to be used for his urinary incontinence. He's on theophylline to treat his COPD. He's on Albuterol, ipratropium, budesonide, and zafirlukast, which is a leukotriene receptor antagonist. So he's on a variety of drugs. So let's take a look and see how these drugs are going to be working. So let's start first with Oxybutynin. As you know, this is being used to treat his urinary incontinence, and it goes in that class of anticholinergics. And so that's the good thing about it, because we've talked about anticholinergic drugs in our neuro unit. And so you can remember, if you look at the side effects of this drug, they're going to be exactly what you learned when you learned about the drug atropine a few modules ago. So you're going to see all these anticholinergic side effects associated with this drug. So patient can't see as well because of blurred vision, having problems sweating, drying up secretion, dry mouth, and it can cause some increased heart rate. So the contraindications for this drug is because it's slowing down some of the GI functions and some of those other target organs that are controlled by the parasympathetic system. These are the contraindications that you see here, and these are the same contraindications that you learned about when you were studying atropine. So keep that in mind as you think about this drug. So as you see the prototype summary, you can see it again talks to you about the action of the drug, which we just verbalized, and you can see some of those adverse effects that are listed there. So when you're talking about this drug, those are the things that you want to be thinking about when you are looking at this drug and to be assessing Mr. Reinhardt for. So keep those in mind. So let's take a look at our next drug. And Mr. Reinhardt also has COPD. Now, to understand the drugs that COPD treats, you have to go back to think about physiologically and pathologically about what's going on in those airways. So if you see this slide, you can see the diagram on the slide that you see a normal bronchus. You've got this nice wide open bronchus, and you have a relatively thin layer surrounding the bronchus, and air can flow very easily in and out of the bronchus. But with chronic bronchitis, COPD, and with asthma, what happens in those airways is they narrow. And you can see the difference here between the nice open airway and this closed up airway that has all kinds of inflammatory changes going on, and it's narrowed. And it can be attached to also secretions, and it can also be causing problems with bronchospasms. So that's the main problem with COPD and with asthma. And we'll talk a little bit in a moment about some of those differences between COPD and asthma. So let's take a look at his medications. So he's on bronchodilators and he's on anti-inflammatories. So those are the two main things that we're trying to treat with drugs to address his COPD, or these drugs can also be used for asthma, because the underlying mechanisms for both of these problems is the fact that the airways are basically narrowing and clamping down. So these drugs are trying to open the airways out by either working on the structural aspects of the airways, or we're trying to reduce inflammation, which will increase the diameter of the airway. Both of them are opening up the airways to help the patient to breathe better. So let's dissect these medications a little bit more. So this is just a nice diagram that illustrates for you the different sites of action, because I know it's always hard to remember your sites of action, but the only way I can remember sites of action is that I picture where they're working in the lungs or in the brain or wherever these drugs might be working. But this is picture of the lungs that really is going to demonstrate where these drugs are acting. So if you look at your inflammatory drugs, these are basically going to be working again in those airways to stop that inflammation. So we're trying to stop inflammation with a variety of these drugs by either reducing some of these substances that are causing anaphylaxis. It's again causes that narrowing of the airway. Other drugs that are trying to block other types of mediators like leukotrienes, anticholinergics, which are basically helping to open up airways from impacting the breathing. We can see other drugs that are impacting the mucus, and again, helping to open up those airways. And so they're all working in different ways to open up those airways and to decrease inflammation. So keep that in mind. So we usually use drugs in a variety of ways, or I should say we use drugs that have a variety of mechanisms to address the underlying problem. So some of these drugs that we're going to be talking about are used for short-term control, and some of them are used for long-term control, and some of them are used just for both short and long-term control. So short-term control means that when a patient is having acute symptoms. So one of the hallmark drugs that we use are the sympathomimetics. And these are the drugs that mimic the sympathetic nervous system. It's going to basically open up those airways. So again, you talked about those, or you learned about those in your module, your neurological unit module, where we talked about the beta and the alpha receptors, but these drugs target the beta receptors, cause them to open up. And you remember one of our prototype drugs was epinephrine. So epinephrine, even though it's not on your med list, epinephrine is important in treatment of COPD because it is one of the hallmark drugs that we would use in bronchospasm. So if patients have an acute attack of airway constriction, we're going to go to epinephrine to be using because it's going to open up the airways immediately. And it could be used in an acute situation when you have a patient with COPD that maybe is having another inflammatory process going on that's really narrowing those airways, and we really got to do everything we can to open up those airways, and that's important. Some other drugs that we use for short-term control are anticholinergics. And anticholinergics are going to be working also to open up those airways. And they're going to be very effective because we're going to be blocking the sympathetic or the parasympathetic system to narrow the airways. We're blocking that response. We're going to open up those airways, which is great, which is what we want to do. And then we use systemic corticosteroids, and we mean by that is IV method of delivery to treat, again, acute episodes. So if a patient's having an acute asthma attack, we would probably do some type of bronchodilator along with giving an IV infusion of a steroid to decrease that inflammatory response because that's what's really acute in that particular patient. So those are just some ideas for what you'd be using for short-term control. So let's dissect those a little bit more. So the beta-2 adrenergic drug is albuterol. And again, you know about albuterol, we've talked about it before, and you can see here are some of the side effects. And these side effects include things that you're very familiar with. These are all sympathetic system side effects. And these are things that you should be watching for in your patient who is taking albuterol. So they'll complain about having the shakes, their hands will shake. Maybe some of you are taking albuterol because you have asthma. You know what it feels like. It feels like your body's ramped up and you're on, for example, a caffeine high. So those are the things that you need to caution the patient about or be aware that they might occur. So another drug that we can use is budesonide. Oops, excuse me, I skipped over one. So let's go back to another one that's used short-term control. And this is an anticholinergic, and it's called ipratropium. And with this drug, it's really used for maintenance. So it's used for some short-term control, but mainly for longer-term control. And basically what it's doing is it's an anticholinergic and opening up those airways. So you're going to see with your side effects here are all those anticholinergic side effects. So you again need to call back that from your memory banks and pay attention to assessing for those in your patient. The dry mouth, urinary retention, and also your cautions are coming from here is going to present a problem. If the patient has benign prostatic hypertrophy, it's going to make that worse. They have glaucoma, and because of the impact of the palpitations and cardiac, that's why it can be a problem with cardiovascular disease. So let's talk about another one, is the xanthines, and that's aminophylline. And aminophylline is a drug that is used for prevention of asthma attacks. It can be a maintenance type of dose that the patient can be on. And this one has a unique effect in that it really targets just the airways by, again, causing them to relax and opening up those airways. So it really helps to reduce the bronchospasm that's taking place. So the side effects you see are here at the bottom. It can cause patients can feel kind of restless, they can feel dizzy, and they might have some palpitations. And some things you need to be thinking about with aminophylline is that if a patient still continues to smoke, and many patients who have COPD or asthma still smoke, even though those can smoking makes it worse, that smoking induces metabolism. So these patients may need a higher dose compared to non-smokers. Also, the way I remember my side effects of aminophylline is that it makes you feel, again, ramped up. And there's also some interactions with caffeine, and those are some things, again, to be remembering. Aminophylline also has a somewhat narrow therapeutic index, so if patients need to occasionally be monitored if they are on long-term aminophylline use. So our last one is a leukotriene receptor antagonist. And this drug specifically targets these leukotrienes, which are very specific receptors in the lungs. And what we're trying to do here with the leukotrienes is we're, again, trying to stop this inflammatory response that is triggering this airway compromise. Some things about it is usually patients do pretty well on these side effects. With the side effects on this drug, as you can see, they just have some headaches, some dizziness, but it can present some problems with liver function and kidneys because it basically can impair their metabolism. So it's important to be looking at their kidney function and renal function. Also, an important thing to be thinking about is that it inhibits the metabolism of Coumadin. So patients would need to be on a reduced dose of Coumadin or very carefully be monitoring the patient's clotting, and again, it might need some adjustments for that. So lastly, many of these drugs are being given with a Metereddose inhaler and or a spacer. So you can see here, this is a picture of a Metereddose inhaler right here, and you can see that it also has the spacer in it. So this is a Metereddose inhaler, and then this is the spacer. So just a couple thoughts about how the patient should be taught to be using this drug. So with a Metereddose inhaler, the appropriate technique is to first shake it. Then you need to exhale. Okay, you want to get all the air out of the lungs. Then you basically want to place the spacer in the mouth. Okay, if that's all you're using, if all you're using is just this Metereddose inhaler without the spacer, you actually put the spacer, seriously, if you're using the spacer, you place the spacer in the mouth. If you're not using the spacer, you basically hold, if it looks just like this, you hold it about an inch away from the mouth. And the way that I always teach patients is about 2 fingers breadth away from the mouth. So then what you need to do, you inhale while compressing the canister, you hold the breath as long as possible, and then you can exhale. After you use it, you basically want to rinse out in your mouth because you want to get that medication out of the mouth, particularly if this inhaler is an anti-inflammatory inhaler, because you don't want to keep that anti-inflammatory steroid in the mouth, and that can create problems with inhibiting the growth of microorganisms in the mouth. So you want to get that out of the mouth. So that basically summarizes the key points that you need to know about use of inhalers, about using drugs to treat asthma and COPD. I hope you find this helpful, and good luck on your upcoming exam. Goodbye for now.